Very warm welcome to the Board of Directors in public, 4th of December. So we've just had a paper stroke, really good. It's a great start to the day. Just a couple of Usman is coming in live to us on the screen, and so is Anil. Thank you, Anil. I know you had some difficulties this morning, and thank you for joining us. And we have Zoe, who's here because from the Central Authorities, and Jill is taking minutes for us. Jill's quite a new recruit in our governance team, so that's great. Apologies for absence. We have Dinesh Gupta, Simon Blake on this line, who's joining us for the private part of the meeting, Anavander Gag and Funny. And Nitin just remains there from this end. And we are quiet. We shall move on with the business declaration of interest. We haven't had any announcements not. The Board of Directors held on the 2nd of October an action arising. Firstly, can I agree them as a correct record? And the actions are matters arising. There was 4 actions. You'll see it in the action log on the paper. So 3 of them are closed and 1 will be is pending. And Jackie,
yes, I just wanted to say my apologies to everyone. I completely overlooked that in my chief executive report, so I will make sure it's in the February one. But my sincere apologies to everyone.
Yeah, and we have it's good. It's a question from a member of the public, and we'll address that now if we may. It's a question from the public about whether the trust has considered approaching agency staff about joining the trust on the bank, or indeed coming on to the as regular employees. It's a very fair question, and exactly the sort of question we need. We've been addressing this for a little while because I think I'm going to ask Usman if you've got any further to add, but we've as everybody will know, we, as most NHS trusts, if not all NHS trusts, are undergoing financial recovery plans. One of the things that we can look at, and we have looked at, is the cost of agency staff. So this is agency staff, medical staff, nursing staff, and others, and it does cost. And we've been looking at that. We've been focusing in on that from a quality point of view. There are many benefits of bringing people into our teams as regular members of staff, and we've done pretty well really over the last year or so, bringing people on, and that will include, visiting wards, visiting community teams, and where it's appropriate, talking to people that are on the agency that want to join our bank, or indeed go for to be interviewed and be an employee of Sussex Partnership Trust, whether they keep to that. And the figures would suggest that we're doing well on that, but we must continue that work because it's so very important. Usman, is there anything else you wanted to add to that?
No, Chair. I think you've covered that really well. I guess all I would add to the written response that we've already given is just we ended the year last year with an agency spend of over £34 million, and we're predicting this year, forecasting at this stage, that our agency spend will be just under sort of circa £25 million. So I think it demonstrates all of those things that you've said that we've been doing. I guess we can evidence the outcomes of those in the actual amount we spend. And I guess I said it in the response, but this is, while the money is important, I think we've all recognised that the quality benefits that come from having our own permanent, substantively employed staff are the main reason for doing this.
Good. Okay, so moving on to the Chair and CEO's report. So the Chair's report, you've seen the report with you. I just want to highlight a couple of things. The AGM seems to be a little while ago now, but we had a really good AGM, I thought, in this room a few months ago. And one of the features we had was the work we're doing with the local authorities around housing for people with mental health problems. So this is partnering with local authorities. It's about one of the social determinants of mental health recovery, providing somewhere for people to live, particularly when they're discharged from our outpatient unit. It's a very good piece of work. I just wanted to say that it keeps getting quoted by the Integrated Care Board, Integrated Care System, as something that we're doing well on. and it also gets quoted nationally as well, the work we're doing, because Chris, the guy that runs it, has got a bit of a national name for the work. So it's just worth saying that. Also, we've had some good feedback on the AGM. We can always improve it. We'll look at how we do it for next year and improve it. But people that attended thought it was very useful and very informative. So I mentioned the 10-year plan in my report. I think what we all need to do in the mental health sector is ensuring that we get the mental health component of the 10-year plan is rich, it's comprehensive, and we get our fair share of whatever will be in the 10-year plan. And coming from a national and doing still a little bit of work on the national side, I think we've got some way to go. I think there's a view around that current climate is so much pressure on the health service. If we're not careful, mental health cannot get the sort of profile that it needs to get. There's some interesting articles in the newspapers and media yesterday about what we know is a mental health investment standard, which is sort of like ring-fence money for mental health. That's really important to us going forward. They do give us a mental health investment standard, have done last year. We want to continue to do that, but you know, there's some anxiety that won't be maintained as we go forward, which will be a great step. And it is here. I'm going to see you. So that's on the national point of view. But I do think locally, from the trust point of view, talking to Oliver, you're involved in a medical directors group and the nursing director group across the country is very active. We play our part, don't we, in ensuring that we influence, and that does get there. It does get listened to. You know, particularly the nurses and doctors that are working together. It really does. Wayne and we do our bit with the integrated care system influencing, and you said later, but you attended the national meeting with chief execs and director of mental health. And these are really important part of the work that we do, because we do need to advocate on behalf of the population that suffer from problems as we go forward. I think governors, our Council of Governors Task and Finish group, Simon said, he ran that for us, and we had a review meeting this morning. Adam joined us, and the recommendations. I just really want to make sure that these recommendations, that report, keeps alive. We keep making sure we review the recommendations, and I'm grateful for Usman and Adam to help us with making sure those recommendations. And I think we've made some progress. We still need to make a bit more, but it was a good, positive meeting. I think the importance of it is the relationships that we've got with our council. Then there seems to be some improvement there, but a bit of a way to go. And then finally, I'll say more later, but I think it's again the work that Jane and I and Anil, the committee in common, Anil, that we have the integrated care system. That's really important because there are major pieces of work. We wouldn't be a committee in common if we didn't do very significant pieces of work around the provider side within the system. Mental health has a really, really important part to play in that, and we are featuring in some early work around priorities for the major piece of work, the committee in common. And we do have a provider collaborative, not a mental health provider collaborative. We have those separate, but a system-wide provider collaborative, which I'll say more about. So some reference to it in the report, but I'm glad to say that mental health, the work that Jane's been doing, actually made sure that mental health was part of those objectives and priorities going forward. This is really vital because, again, if we're not careful, you know, we could be concentrating on all the physical pressures in the NHS in our local community, and it's up to us to make sure that mental health is covered. That is it. So I'm going to take questions, and we start with Kathy.
Thank you. I think it's really interesting the risk that you've identified around being squeezed out, if you like, in terms of the 10-year plan thinking. So the other big driver is looking at the number of people in the country now that are economically inactive and the pressure that brings to the state, and a significant proportion of those who are affected with mental health issues. And the ICB is actually on duty to contribute to the local economy. It's one of their objectives. So I think if I would want the new government and national policy to take a much broader perspective of health. I sat in on one of the 10-year plan working groups on prevention on Monday, and I think it's really important that we take a broad view and don't forget the contribution we make, that health is an asset to the country and an economic asset. So I think that should be another driver for our thinking.
I think that's absolutely fantastic. And the Mental Health Foundation, big charity that's around mental health promotion and prevention, they've done a piece of work recently which followed on from the major piece of work Paul Farmer did, Chief Executive of Mind, when it was, which is £100 billion lost to the economy every year. £100 billion. I mean, these are huge numbers. It's very hard to get your head around. Some organisations have taken that number and laid it down to what the waste is for them, and to do some work on it. So that would that gets businesses to make sure they look after the well-being, mental health well-being of their staff. So I think we're right, the ICB, and we mentioned it, but I don't think we mentioned it enough. So thank you for that point. Okay, thanks very much. Moving on to the Chief Executive's report.
Thank you. I thought I'd start by building on that really. I was yesterday and the day before at an event in London called the Mental Health Chief Execs, Mental Health and Learning Disability Chief Execs. And I have to say that one of the things I was really struck by is how strong the presence of mental health is in the ICB. It is talked about when we think about the work streams of the Provider Collaborative. One of them will be closing the mortality gap for people with mental health and learning disability. We've had an audit, the ICB had an audit of their MIS funding, and it came out as a positive audit result. And I am seeing more and more my partners across the system talking about mental health and learning disability in a different way and in a curious way. So when I say curious, I don't mean curious, with curiosity is what I should say, with curiosity. So I think that we are fortunate to be in a system where there is an openness to think differently about mental health. But at the same time, I think we can't be complacent, because with the pressures on every provider, people are going to try and push forward different agendas. But I think we're on a really strong footing in Sussex, if I'm honest. And I think that's been a work of many people across the trust, not just the executive team, but across the trust, in laying that foundation over the last 2 years. And I would say as well that Adam Doyle, the ICB Chief Executive, is a strong advocate for mental health, which I think is really helpful. So I'll take my report as read. I won't go into too much detail, but I can't help but talk about Combe Valley. So Combe Valley is our new 54-bed hospital that is being built at the moment in Bexhill. Sean and I were fortunate enough to go to the topping out ceremony on Friday. I've never been to a topping out ceremony. I have to confess I didn't know what a topping out ceremony was, but it was very interesting, and we were able to walk through the site with hard hats and sign one of the beams that is going at the front of the hospital with the Lord Lieutenant for Sussex, who came on behalf of the King to represent the King at our topping out ceremony. It was attended by... It had to be quite a small group of people due to the health and safety aspects of being on a live building site, but we were able to have a service user there who's been involved in the work, and someone from the ICB and some partners. So that was really positive. And then Sean and I went afterwards to the Department of Psychiatry, who will be moving into that hospital, to see, to talk to the staff and think about what they're going from to. And as a result of that, we're thinking about how we involve them more in the development of the operating policy for the new move and development. But it's really exciting, and I'd encourage you all to go over at some point to have a look. You want to know about our organisational strategy? I won't go into any detail now, because that will still Colin's thunder for later on the agenda. The annual planning process for 25-26, obviously we haven't had the planning guidance yet, but that has not stopped us starting. So, and I would say we started at this time last year. So when we started the work this time last year, those of you that were on the board at the time will remember that we started thinking about a 2-year programme that would get us into financial run rate balance, and would be a programme of change where we developed ideas from our senior leadership team across services and sort of developed a library of initiatives that could be cases for change, quality, impact them, and decided which ones we would do last year and which ones we will do next year, which has put us in good stead for next year. But we are continuing that approach as we go into the next year. And we're joining a system meeting, some of us on Friday, where we're looking at what we could do as a system to improve quality primarily and to improve the financial run rate across the system. And it's important that we work in partnership. It is no good if we make all the savings in SPFT, but inadvertently it bulges somewhere else in the system. We have to see the financial position as the Sussex position, not just the SPF position, although I do acknowledge as a sovereign board we are accountable for our budget. So, but it is something we need to keep live as a conversation. And likewise, the other providers are working that if they are making some changes, it won't have any unintended consequences on us. And I think that transparency that we're developing as a system is really important. But, or should I say, when you are working towards a £25 million saving for 2 years running, that comes with significant organisational change. And I do not underestimate the impact that has on our staff. It is hard enough when you're doing the usual SIPs, and it's hard enough when you're doing one major programme in a year, but we're doing a number of major programmes and a lot of staff are impacted by that. And there are strong feelings that we are listening to, and during the consultation process, we are going through every bit of feedback we're giving. We will not be able to please everybody. I think that's really clear. We won't be able to please everybody and do what everybody else wants, but what we are committed to doing is provide high quality care, meeting our performance targets and meeting our financial responsibilities. The triple aim with population health of the NHS, because we are stewards of public funds. But that doesn't mean we can't do that with compassion and with listening. We've got our IQPR in the pack, so I won't go into details. But I think for me, the thing it'd be nice to, I'll sit here and I could tell you all the positive stories, but I think it's important that I talk to, we had our quality performance reviews with our 4 divisions last week, 2 on one day and 2 on another day. I am not confident that we are on track to recover risk assessments, care plans and our complaints at the moment. And I put some quite strong challenge into the room that a lot of the actions that were coming in were quite transactional, like clear up your caseload and sort of that kind of thing, rather than actually we're going to do this many this week and this many that week and have a clear trajectory. So I would recommend that the Quality Committee have quite close oversight, as well as us as an executive team, of risk assessments, care plans and of complaint response times. And there is a question for me. So we have performed well in this area before and not in other areas. And now we're performing well in some areas and these aren't so well. So there's a question we've started to talk about in exec team together, is how we maintain consistency and performance rather than bulging and dipping and flowing, and how we get early sight of when things are deteriorating and act quickly, but also ensure we have devolved leadership where we're trusting local leaderships to manage this. So it's an ongoing conversation we're having as board, but I would be really grateful for the Quality Committee's oversight and scrutiny of that as an executive, as a committee, so that we are being held to account as an executive team on those areas. The other bit, I think, just quickly to say, is we have a positive practice awards. Thank you to those that attended. It was a phenomenal event, and there are lovely photographs that have come out of it that I'm sure we'll be able to share. I was immensely proud of the staff and the work that they do that was celebrated that night. And also there were over 300 nominations that came through, and that is a small, we can often focus on where things go wrong. That is the tip of the iceberg of positive practice that goes on day in and day out in this trust. These are the ones that people took time to nominate. There are plenty of others. We're going to get the date in the diary early for next year so that everybody can be there and everyone can be part of the judging and the presenting of awards. It is a really memorable evening, and it's lovely to be able to celebrate with our staff. And finally, I just wanted to acknowledge that the NHS Finance Value Makers Innovation Award was given to our team, which is really exciting, and I'm so proud of them. And that was in relation to our nurse agency spend, which links in with the public question as well. There has been significant work around reducing nurse agency. When I first came in as chief nurse, the vacancy rate was 35%. It was highest in the country. And I think last month, correct me if I'm wrong, Teresa and Zoe, it hit 14%. That is really significant and has had an impact on our agency spend. But the reason I'm particularly proud of this award is that it wasn't a finance award, it wasn't a nursing award, it wasn't an HR award, it was a trust award about everyone working together in partnership to achieve that aim. So it's real partnership working across directorates. So I just wanted to end on that celebratory note.
Yeah, okay, thank you very much. Right. Just the one question that comes to mind, I think we'll all be thinking about is the quality indicators that you picked out, the risk assessment, care plans and complaints. And it's as we discussed here on several occasions, it's a relationship between quality indicators and the financial recovery plan. And the more we move on the financial recovery plan, we're very careful about what the effects on quality. The question is, what systems do we have in place? Just remind us to monitor that effect between these quality indicators and the work we're doing.
Reasonable on the phone. I mean, they chair the Quality Risk Management Committee, which is where the risk is held.
I suspect the answer to is the quality indicators, is there some relationship between the financial recovery? But the answer to that is yes, there is some relationship. But is it, how do we know that and what systems we have in place to keep monitoring that closely?
But I don't think that because the care planning and the risk assessment remains a concern, even though we are seeing improved rates of staffing. So we've just spoken about in terms of reduction in nursing vacancy. And we know through lots of international research that will say that the greater downward staffing you have against temporary, the savings of. So I think there's lots that we can talk about, but the bottom line is, if you are responsible for case patients, then you are responsible to ensure that your patient has a care plan and a risk assessment that has been designed and developed in collaboration with them and their family. So that's the conversation that we have. That's the clear expectation that has been made in relation to trajectories monitored very closely with each. And I hear Jane's point around QC oversight. Absolutely.
Kevin,
From a quality committee perspective, I think there is a scorecard, there's oversight, and I think there's 3 indicators of the world scrutiny, I think at a top level. And so I guess if the challenge back from Jane is to make that scrutiny a bit more targeted, then challenge accepted. Thank you.
Sorry, can I just come back on that? So I think the challenge is to pull back on the scrutiny and the challenge. I think it's really important that we're supportive of each other, but where we're not. So when I look at the trajectory for those 3 metrics, they've been on a steady decline for quite a long time. At what point do we escalate it to 4 and say that's so it's a challenge that.
yeah, no, that's really good. Let's take Dan, Oliver and John and then we'll.
Just briefly on complaints, and we did scrutinise this yesterday at Quality Risk Management Committee. I would say to the board that we remain focused on consistently meeting that response time performance. We haven't done over the last 2 months. We have increased the number of cases that are being closed through early resolution. That was a policy change we introduced 15 months ago that involves having that conversation early with the complainant before a written response. But the response time performance over the last 2 months is not where it needs to be. And we're working directly with divisional leadership teams on that.
Yeah, just wanting to make clear also that the change programs that we have got at the moment are not driven by finances and their timetables are. And effectively, they are the transformation programs we need to be doing anyway, and they are really focused on actually making the changes that we want to see in people's care. And as Teresa says, the systems we have in place are the systems we need to have in place. So
John.
It was a similar point to Oliver's, Chair. Just going back to your, I think, some more strategic comment, are we cited on the quality impact of any of the potential financial recovery changes that we make? Absolutely. So if I think about the processes of scrutiny through QRMC and Quality Committee, and I chair the Financial Recovery Operational Group, and I can absolutely say that there's a multidisciplinary group which has clinical directors, directors of nursing and quality, and managerial colleagues. So it feels very much a collective effort. And everything that we develop, as Oliver described, will be subject to quality impact assessments. So we are absolutely cited on the quality impact of the financial initiatives.
Brilliant. I'm really grateful for that. One from Kevin, then we'll close with this.
Sure, yeah, I think the first question I ever asked it. You've described an extraordinary program of change, of business as usual, of whack-a-mole with keeping everything sort of down, like, and it's almost maybe so over to comment about, I guess, assurance as a board that change is being managed and handled, and there's capacity in central change management functionality to make sure we can handle all of that. It's always about getting things done. Well.
Yeah, you answer and then as well.
Yeah, so I am confident. I'm confident that things are stretched, but we're responsive. So we have brought in additional resource when we've needed to, and we haven't shied away from doing that. It's under constant review. We have a number of different places, mainly chaired by Usman and Colin, where that is scrutinised and papers come to executive committee when we feel that we need additional resource to support it. And it's an ongoing discussion, and it's certainly one that I have to say Colin is very good at raising, particularly around the capacity within the senior leadership team to hold that level of risk and that level of work. But it's a live conversation, and I wouldn't want to become complacent on it.
Building up capacity over time as well.
And that bringing in extra social media, I've seen that happen, and I have not seen it happen in other areas, because you just don't have the financial capacity to do that. Well, Usman does make an allowance of that, and it's the unintended consequences, the things that you don't predict when you design these plans. So it is good. So I will come to you, Anil, but Usman first.
Thanks, Jeff. I was going to say one thing. It's great things CFO not to have to be the first one to answer that question, when I think it shows a sign of the multidisciplinary nature of the change programs that everybody else is able to talk about it like that. But I guess just to formally note that point that you've raised around how do we take assurance. So we've got the integrated quality performance review, which looks at all of the metrics, not just FINEX. So if something was going off, one of the first questions we'd be asking is what driving that, and is it one of the cases for change? As John said, the specific cases for change have all been quality impact assessed. They all go through regular review, both through FROG and then subsequently through the SSIG. And so we've got another line of assurance there. And finally, we've always had our overall recovery program and the governance structures around it reviewed by internal audit, and we have done so again this year. So to provide an additional line of defense around that very important point of are we making financial savings that are potentially having quality impacts, and are they, or do we know about them? So I guess I just want to formally just sort of recognize those specific points.
Thank you. Anil, final point, please.
Chair, if I could, an observation and a question. So the observation is this. Jane, thank you ever so much. As I'm coming to find your candour and insightfulness, you could easily have skirted over this. You didn't. And other colleagues for addressing that, Teresa and others. So one of the questions has been answered and asked and answered. But my other question, if I could just press you, Jane, others. You talked about we need earlier sight when it comes to variance and deterioration in services, and you set out that you were concerned that the actions taken to address those issues, be it risk assessments, care plans, etc., were somewhat transactional, if I remember rightly. what, if anything, does that say about our broader cultural approach in the trust? And other than the CEO quite rightly setting out her, in this case, expectations firmly, do we need to do more to address, so it becomes baked in, to Teresa's point, where it becomes native to what we're doing?
I couldn't agree more, Anil. And I think there is something about, as we go into the new year and we're thinking about our quality improvement approach, about how we bake that in, because you're right, it shouldn't be me doing that, but I am the final safeguard if some, of trying to pick it out. So we had a plan that came to us because we noticed something wasn't right and that wasn't strong enough. But I think what that's indicated to me, there are some development needs. I have come from a background of quality improvement methodology. This trust hasn't had it embedded. And I think so there's an expectation from me that people are using that, but it doesn't match what people's skills and abilities are. And so that will lead into the work that Colin will be leading as we go forward, that we talked about in the board strategy about our quality improvement methodology. And that is really data driven and narrative driven and has really clear metrics and local ownership of the problem and the results. But it is going to be a cultural change for this organisation that we need to be on the journey of.
Thank you. Excellent discussion as always. Thank you. Yeah, very good. And thank you for your report. Moving on to the quality and safety part of the agenda, there are 6 reports to receive, and the first one, Kevin, the quality.
Yeah, obviously we spent the entire last quality committee looking at risk assessments, care plans, and staff training. I'm impersonating Anna today, so apologies if I don't sound quite like Anna. Yeah, it was I think it was a good and reflective and I thought quite purposeful quality committee. There were 4 major reports we looked at: learning from deaths, guarding and safe working, safeguarding and report, and medicines optimization. 2 of them are back on the agenda today, I believe. And the medicines optimization, the thing that struck me from that was electronic prescribing and the need to do more faster and better from that. You'll note assurance on safeguarding staffing levels and in the guardian safe working report, the working hours of junior doctors. We covered following the publication of the Callacane review, note partial assurance in assessment and treatment services, and that is on the agenda for today. We were assured the risks are being managed, and there's more work to be done to strengthen the quality and risk management governance processes. I think in terms of the reports themselves, I think they're so much better than they used to be. Yeah. The detail and what we're seeing is so much better, and there's definitely a lot more scrutiny there. And data, I think, is getting better in the reports. I think a long way to go on it still, and that's the biggest gap. It's interesting hearing a patient story about being assaulted with proms. Yeah, getting that balance right between recording patient and clinician outcome measure, but still going some way to getting some kind of outcome measures, I think is probably an important part of our journey and on the strategic plan, which was good. There was a little bit of scrutiny on the exec, I think. In particular, we raised the issue of waiting times from allocation and assessment internally into actually getting intervention. And we've asked the question a number of times over the months. So we'll continue to ask the question. We'll work with Teresa and Oliver on finding a way to report. It came out of CAMS in the first instance, but now it's been broadened to have a look at those internal waiting times and whether they're real and I guess what it means for patients over the next few quarters. There were some concerns about the lack of capital spend and how that then relates to safety issues like anti-ligature doors. And we were impressed with engagement with families in the PSERF and patient safety side of things. That was really good. And lastly, we did welcome a new governor, Adrian Morrow. Yeah, so that's sort of an update from me. Next time I'll make sure to be a bit more clear about the scrutiny. Thanks, Jay. Thanks for the note.
But you said that scrutiny has got better, and you also said that the data.
But the data, I think, is a really good point about the data can get better and can get more and get various, and then sometimes assessments and care plans it's the knitting, right? That's it. So if there isn't a productive, meaningful care plan, then what is the onward care pathway and what is the journey? So I think it's yeah.
We'll keep the debate alive around capital investment. Poor over the last few years. It's interesting how you mentioned earlier about the media retention for mental health specialists and Lord Simon Stevens, who of course was an NHS chief executive. He weighed it in support of mental health. Need for,
Moved in the HSJ this morning or yesterday about trust beginning to pool capital resources, and I'm not quite sure what the rules around that are, but
Great. So on to some of these reports that you mentioned, Kevin, and thank you. Learning from Des.
So I'm only going to pick out a couple of things from it, and you'll note that the trust touches 630 odd deaths a quarter. So there's a large number of people who we have to have some sight of. And just to put it into context, 43 of those we then do a mortality scrutiny review, and possibly a bit less there'll be a patient safety incident investigation conducted as well. One of the challenges we have, and it talked about it in the report around reviewing the terms of reference for mortality scrutiny, is how do we ensure that we feel so most of the vast majority of deaths are natural causes, but how can we be sure of them? And so that's one aspect that we need to work on. And then the other aspect that I think Kevin's comments about the quality of the report changing, what you're beginning to see is in the report where we are looking at when we have people who die prematurely. We're looking at, and most people, sorry, my hair needs to so funny. Most people when they die prematurely are dying from preventable causes. And so that then calls into question how are we looking after people's physical health, and so on. And also it raises the questions around our data recording, health inequalities, race, etc. And so that's where really the other area of focus for us over the coming months has to be on reporting that in a way that we can make sense of the data in a way that's digestible and understandable, and then we can have conversations with our clinicians and frontline staff to change their services so that they can think about from a QI point of view, where do they need to focus, where do they need to be creative and so on. So I'll stop there, taking questions.
Anything? I just thank you for the comprehensive, clear report and information on it, and we'll keep the work going.
Sure where to bring this in. I'm heartened that comorbidity and dual diagnosis on the strategy. Notice that it's one of the predictive factors on the death reports, but also in quite a number of, it's threaded throughout the papers today about drugs, alcohol, and our approach and our strategy around that, if you like. So yes, it's almost need to make that real, if you like, that our approach to comorbidity with alcohol and drugs.
So I'm really glad that you raised it. In the patient safety investigation, certainly in the last year, we look forward on our consultant nurse for co-occurring conditions and diagnosis to be able to support us with that learning. So that's one thing. And we've also put this as a local class group in our patient safety plan. And there have been a number of incidents and times where this has been really prevalent. So that's some of the actions that they're taking. I think it also raises the issue about staff training and development. So we have been focusing quite considerable efforts on staff training and development in some of our core services recently.
And across the other side, drug and alcohol treatment services side of the world, I think they need is if it's to reach out there. Look at the most recent drug and alcohol support from vitamin. People run people mental health, so we need to reach out to those parts.
Yeah. Okay. So three quick responses. Start with your comment.
Yeah, absolutely. Pick up the point, Kevin, and obviously we put it into trust strategy. So for me, there is one of the requests of the board in Q4 when we start to look at, well, what does the strategy look like in terms of year one delivery, will be to do those kind of cross-check pieces that go, okay, you've written drug and alcohol into strategy, but what are you actually doing? What's the demonstrable difference that we are hoping to make next year in terms of the way we are working with other services or the way we are meeting people's needs? So I think that'd be a really welcome challenge to bring back into this conversation in Q4 when we're really starting to get into the detail.
Right. Let's take a look at
I'm just stepping back a bit from the detail, of the information, just trying to understand more about the cause of death. Are we seeing trends in any of these things? Like, is there, like, with some of the patients, is there any indication that we could have or seen that those patients were more at risk? Is there anything that the staff are saying that, we needed a lot more work for this person, or are these mainly people who were under the radar and then suddenly we found out something happened? I'm just trying to think, is there a way that we could have prevented or seen something happening?
So we are seeing trends, and so cardiovascular disease, smoking, vaccinations, cancer screening, and all these sorts of things have a massive impact on people's outcomes. And so if I take learning disability, for instance, some of the medications we use can have side effects which increase the risk of cardiovascular disease. If we're not scrutinising those prescriptions, if we're not giving GPs clear information about how to monitor it effectively, and if we're not actively engaging people in order to have blood tests and so on, then we expose them to greater risk and harm. So it's really important that we use the mortality scrutiny group to collect those themes and then to shape the services. So in the LD services, they developed a scheme where they to improve communication with the GPs about antipsychotic medication use in particular. So that's just an example of the sort of thing we need to get to. But to be honest, I think we're still quite early days, really. The mortality gap is a national and well recognised issue, it's going to take quite a different approach to really address it, and that's where the neighbourhood mental health teams comes in. So that's where we're integrating our services with our GPs and other providers. And to pick up Kevin's point about substance misuse, so having CGL embedded in those neighbourhood teams, Change, Grow, Live, it's the principal substance misuse provider in our area, and so they provide counselling and up to residential rehabilitation programs, and so we want to have those colleagues embedded within our services so that there isn't this divide between, well, that's mental health and that's substance misuse and so on, because that's also another major cause of early death.
Well, I'm so glad you included the side effects for explanation and how we monitor that. Yeah. Okay, so while we're still with you, Oliver, the Guardian State Working.
Yeah, so this report, it looks at the performance of the out of hours work provided by medical staff. And it's particularly interested in making sure that medical staff aren't exposed to the shift patterns which are unsafe through long periods of time, excessive workload, etc., and that they are also robustly filled. So the big take home is that there were no fines in that quarter, so that's one good sign. However, I'm still actually far from confident about the performance of our rotas. You will note that 40% of rotas had to be filled by cover. So that's really, although we are largely able to provide, fill those shifts through internal locums, it's still not desirable, frankly. But our internal systems are quite robust at finding people, and so in the end, there was only one occasion where we had a safety alert when someone, I think it was in Hastings, did not turn up for the late shift, so there was a gap from 5 till 9 o'clock. So there was a cross-cover arrangement made with one of the other local hospitals. Not ideal, but it did happen on that occasion. There have been a couple of cases where the consultant psychiatrists had to come in and act down. Again, not ideal because that then disrupts delivery of work the next day and so on. I will say that this is definitely on my radar. There are opportunities, I think. So you may be aware that there's been a rebalancing of training placements away from London and to the regions. We've benefited from that. And there's also been an expansion of training placement more generally. And this will probably mean that we can actually what we call a 3-tier on-call system, where you have a CT, core training doctor, and a higher specialist training doctor. Sorry, resident doctor, and then a consultant. And at the moment, we only really have a 2-tier system. It's much less resilient, so there are opportunities probably to merge a couple of the rotas and also to create a 3-tier. But that will take probably about 12 months to sort out. That will create a more resilient system. There are also, I'm just going to flag up. In the next quarter, you will see an increase in the number of reports because we've identified an issue with handovers. The handovers are not adequately included in the rota, but we're working up on a plan to create what we call a hospital at night meeting in order to manage that. So that's where I'll stop there for that report, if that's okay.
So I just thought I'd say something because I'm aware there are a number of particularly non-exec directors that haven't been here previously, and some of you may be aware that it is usually the Guardian of Safe Working that would present this, maybe not the Chief Medical Officer, because it is meant to be an independent report. One of the agreements that Peter put in with Sarah is that if she wasn't concerned, she was happy that the CMO would present it on her behalf, but that she had open access to the board whenever she wanted. The other thing I just need to say is obviously this paper was written in August when Peter was the CMO, which is why Peter is the sponsor and Oliver is presenting it, because at the reporting period for this paper, Peter was the responsible officer. So, but going forward, it will be Oliver. So I just thought it's worth clarifying why the Guardian of Safe Working isn't here and why Oliver's presenting it, not Peter.
Yes.
So I have spoken to Sarah about
I've got a question. I think maybe it's done in another paper somewhere else. So this looks at junior doctors. So I'm just trying to think what's happening with the other staff. Like, did the nurses are they working safely? Like, where's the report on them?
Sounds not cheap.
Sorry.
There is an annual establishment review that comes through Quality Committee. There is a 6-monthly interim that comes through the Quality Committee, and through the QRMC, which is the Quality and Risk Management Committee, on our fill rate. So we scrutinise the monthly fill rate for every month in the Quality and Risk Management Committee. So I hope that.
So are we seeing similar levels of, as the junior doctors to the other levels of staff?
So we're seeing for registered and unregistered nurses in our wards, is that for registered nurses, the fill rate daytime is around 95%, overnight it's around 90%, and for health and support workers it can be very high, so way over 100%. Now, the narrative that we will receive about that is linked to acuity, it's linked to enhanced occupation. We will see more health and support workers on the shift than we are budgeted for, due to the acuity and due to the need that we have. We look at that on a monthly basis. It does come
So you'll see it.
So through the board, we have a 6-monthly, we have an annual report that comes through the board, and then 6 months.
What's the percentage when it's like, this is dangerous? I mean, is it different for each one? Because you said one was 95% during the day, one was 90%.
We would say is 30%. We don't have anything as an overarching figure of under 80%. We do have occasional boards whereby it does drop under 80%. We scrutinise that heavily through QRMC. Okay. There were a couple of examples of that this last week. We looked at and scrutinised. We do have more level going that's coming through.
Well,
Let's go to Kathy, but just on that.
well, just to add to Teresa's point, really. So there are over and above the formal governance processes that's been described, there are roster check and challenge processes at every ward level carried out by divisional directors of nursing and quality, as well as Teresa and I sit on an agency panel every day where there is scrutiny around what we call safe care. So that's the roster which says today there's this percentage of ward nurses, this percentage of HCA. So the level of oversight is down to ward level.
Helpful.
I mean, I'm going to ask my question actually.
Yeah, okay.
But I was also, as well as the fill rate, I just want for people missing opportunities for education and training, so that obviously budgets for that sort of thing sometimes come under pressure as well. So I just wondered, to Jane's point about we need to be developing organisation skills and capability. Are you sure that staff are getting opportunities?
Yes, they are. They are. And certainly, for example, this last week, our focus was very much on the prevention management and violence aggression training. And we're confident that all staff that haven't done it very recently are booked on. And staff are being released for training.
Just a point, if you can, then we'll move on to the next. What?
I think the points have been covered off. I was just going to say that within the board IQPR at the back of the deck, we have got listed all of the safer staffing positions for all of the wards, and you'll be able to see from that we're, again, as Teresa said, we're on average over 90% against all the day charge nurses and against over 100% against HCA. So I think that is how we monitor the fill rate. So in terms of how would that compare to what Oliver just presented, and then in terms of StatMan, that's all monitored through both the People Culture Committee and then up through QC. So I guess that's just the other bit. I guess it's just worth recognizing that we have to do it the way we do it for junior doctors because it's mandated like that. So it's just that it's not that we do that specifically just for juniors and then don't do it for everyone else. It's just that the way we monitor it for other staff groups is through our normal processes that exist. But for juniors, we're required specifically to do it in that very specific way that Oliver set out.
Thank you, Usman. And finally, from you, Oliver, the medicines optimization.
Yeah, so I'm just trying to remember when Helena Bird, our new chief pharmacist, who's not new anymore, when she joined the trust, but
It started over 3 years ago.
just 3 years.
before I-
Okay.
Yeah, so not really new.
New to me. Helena's been redesigning the approach to pharmacy more broadly in the organisation. So with the development of the divisional structures, the big task is to realign people's line management within the divisions, whilst retaining a centralised function to manage governance and regulatory compliance. This is meant, and there's lots of reasons why we need to do that, not least because actually there's an awful lot of negotiation we need to have with our external partners and the ICB, formulary, for instance. Kevin also mentioned the EPMA. So there's an awful lot of big ticket items that are on our radar. A part of that means that she is wanting to redesign the governance framework. So you will see terms of reference for key meetings that are going to do that, and the move to a medicines optimization group and then a pharmacy leadership group and so on. So that's really what this paper's about. And yeah, so I can take any questions.
Okay.
I'm obsessed with everybody describing that. But is it
Sorry.
July 2024 that we're looking at?
Yeah, so let me tell you where we got to with VPMA. It's because it's going to be tied up with the new electronic patient record system, and that's a lot. There's a lot of work we need to do to get there, and it's a very complicated program. And in my last place, it took almost a decade to get there. I don't think it will be as long.
I've done and run them. And
oh, yeah, okay. Well, so yeah, I mean, it's very much.
You'd be aware it's beauty business is probably number one gripe, concern from doctors.
Yeah.
Okay, bless you. Thanks very much indeed. And Teresa, you have a colleague.
I do, yeah, I saw him
I'll come.
through, so
Adam.
in the picture.
Yeah. So over to you regarding safeguarding and report.
Thank you. So I'm just going to introduce Paul Burton, who's the safeguarding adults, and he's coming to present our annual safeguard, our annual assurance report of safeguarding practices and within the trust and meeting on statutory requirements. So hi Phil. Hello. Hi.
Hello, Phil.
I felt.
I was just introducing the annual report. And I was about to say,
Yeah.
Phil to present the report.
Yes, that's fine.
Perfect.
Yes, so I'm Phil Blurton. I'm the head of safeguarding adults for the trust. I know many of you, but not all of you, and I think it's the first time I've seen some of you face to face. But thank you for inviting me today to come and present the Safeguarding Services annual report. I'm one of the authors of the report. I can't claim it's all my own work. The other person who wrote it is the head of safeguarding children and looked after children, Martin Ryan, at the time, although that has now changed. The first thing I'd like to say is we're now in December, and this covers last year, so things have moved on in some areas quite a bit since then. But there's still quite a lot that I think I'd like to bring to your attention for last year. The first thing to say is that as a service, we were fully staffed, which was important because it allowed us to deliver our core functions. And the safeguarding service core functions are training, safeguarding training, safeguarding advice and support, mainly to our frontline teams, but across the trust as a whole. The monitoring and analysis of safeguarding data, of which we've been working hard to make it as relevant as possible, and our full engagement in the multi-agency safeguarding work of the Children's Safeguarding Partnerships and Safeguarding Adult Boards across East Sussex, Brighton and Hove and West Sussex. So with the fully staffed team, we were able to do all those things. And I know in some parts of the trust, it's a challenge with keeping sort of full complements of staff. And we were fortunate last year that we did in our service. There are 13 pages of the report, so I'm not going to go through it all in detail. I thought what I'd do is pick out some of the highlights, some of the new areas of work that we've been developing. The first one I thought I'd mention is the 2023-24 business year was the first that we had full reporting of safeguarding data within Ulysses, our incident recording system, which was an important development and took a long time to put in place. It's important because prior to that, we relied on spreadsheets, emails, and also approaching our safeguarding partners, the local authorities, to ask them about the safeguarding work that we were completing, which I didn't think, well, it was a bit embarrassing at times, really, that we didn't know ourselves about our own safeguarding activity. So it was really good that this was the first year that, first full year of safeguarding incident reporting within Ulysses. And that gives us much greater consistent data across our services about our safeguarding activity. Another development in the year was we started recording our own internal data around the safeguarding consultations that we as a service provide to our frontline teams. So this is where people in operational services have got a safeguarding issue and they want some advice and guidance about how to deal with it. So they approach us as a service, and we set up, usually it's a virtual meeting online, to discuss their safeguarding concern with them, to support them in getting the response as best as it can be. And we've started recording how many of those we're conducting, but also what those conversations are about, because that provides interesting information about where our staff feel they need the greatest levels of support. And that highlighted, for instance, that most of the consultations were about domestic abuse. Nearly half, in fact, were around domestic abuse. And that's helped us think about what do we need to do with regards to our training. Is there something more we need to do around training for that? And what is that issue about? And I'll come on to some of what we've done there. In fact, one of the other major achievements of last year was to implement new domestic abuse training across the trust. That picked up on some of our feedback through consultations, but also the Domestic Abuse Act of 2021 to bring our training in line with that, and recommendations coming out of domestic homicide reviews around recommendations that the trust needed to do specifically, but also general recommendations for all agencies around domestic abuse. So in December last year, the Trust put in place new domestic abuse training. We worked with Safe Lives, which is a national charity dedicated to the removal of domestic abuse. And we're quite proud of that as an achievement. It took quite a lot of work to get that in place. And we actually agreed yesterday at the Quality and Risk Management Committee that we would require staff to complete that by the end of the first quarter of the next business year, because it's only needs to be completed every 3 years. And if we wait, that would be another 2 years now before everyone completed it. So based on some of this information from our consultations and concerns around some aspects of domestic abuse, we've done that as well. Another development, this was the children's team. They've been developing a tool called the PAMIC tool, Potentiality for Adult Mental Health Impacting on a Child. And that's a tool to help frontline staff understand the impact of an adult's mental health on the children that they care for, and direct them about what they might need to do or not do, depending on the outcomes of using that tool. And that's currently on trial now this year in East Sussex. The service also was part of really important work around sexual safety of staff and patients. They've been part of the working group that developed the new trust policy around sexual safety that was published at the beginning of this business year. So we've been key to that development. And we've taken an active role in many of the safeguarding adult reviews that have been going on. And I've put in the report some of the key themes there. I think one of the key themes for the Trust is around dual diagnosis. Some of the safeguarding adult reviews that we've been most involved in have been where people have co-occurring conditions, and the challenges of working with people with those presentations alongside other agencies. Training compliance. Our training compliance has generally been good. For safeguarding adults, we've met our training compliance figures of 85%. For children, it's been a bit below that last year in 2 of the training courses that we provide. I had a look at it at the end of November, and we're now only 1 of them isn't meeting our compliance levels. It's just below the 85%, which is a challenge. We've put on extra training to try and help with that, but I think the challenge isn't so much about us providing the amount of training. It's sometimes about frontline teams finding the space to actually attend and complete that. But the figures at the moment are only just below the 85% that they should be for those training courses. We're also responsible for the Prevent service within the Trust. We have a senior clinical lead for Prevent and a Prevent practitioner, and I represent the Trust on the various Prevent boards across Sussex. And I think it's fair to say we're one of the few trusts that has a senior clinical lead for Prevent, which is a part-time consultant psychiatrist, and they've been increasingly asked to present to other trusts about how we manage Prevent within this trust. And I think probably we're ahead of some actually on how we do that. It's integrated within the safeguarding service and allows us to provide, again, a good consultation service to frontline staff. The service dealt with the challenge of the Trust redeployment programme at the end of last year. Safeguarding service contributed to that. I think it's fair to say for many teams involved in that, it was quite challenging, but I was really pleased that we were able to contribute. I myself was redeployed for 2 days to the mental health liaison team at the Conquest Hospital in East Sussex. And I took the view and tried to encourage that within our service, that this was an opportunity to see on the front line how safeguarding was working and to directly feedback to frontline teams and provide almost a bit of in-reach, really. And I think those of us in the service who did do it, although many initially maybe weren't that enthusiastic, I think actually afterwards they did appreciate that they'd learned quite a lot from it, and the teams that they went into learnt from them. So something that initially was quite challenging, in the end, for those who did it, was a positive experience. And for the 3 months that we did that, we had to step back from some of our safeguarding work, but because it was a limited period, we didn't feel it created a safeguarding risk to the service, and was actually quite beneficial. So I've kind of scampered through the highlights. There's a lot of information in there, and if you have any questions, I'll do my best.
That's really good. Good report. Thank you for all the really important work you're doing, for your leadership. just that last point about the redeployment. One of the things I'll take away from this is I'm going to know a little bit more about Prevent, the part-time consultants and how people work on Prevent. I'd like to know a little bit more about that outside. So well done, and we've received the report, Jeff.
So I want to say personal thank you. So I think it's brilliant. And I say that because there have been a number of times during this period where I have been reading complaints and had a niggle that something safeguarding was going on. And I have found your team extremely responsive and thorough in your response, but thoughtful and compassionate as well. And it's led to training. So I think I've seen very clear evidence about the tangible impact and the passion with which the compassion and accountability with which your team have worked over the years. So I just want to say thank you. I personally has found it very reassuring and assuring, but also helpful. And it's nice to see you in person after such a long time.
Yes, so you can take the thanks back to your team, but then just to make the important leadership that you and Teresa are showing. Colin and John will close out. Yeah, sorry.
Just to add, really, really excellent report. I guess for me, the one thing just sort of thinking forwards is around where we've got some of the data, it'd be really helpful to understand it on a kind of a weighted population basis, because I think it'll change the way that we look at it, particularly if you think about West Sussex population demographics as opposed to Brighton. The adult safeguarding incidents are very, very similar. If it was a weighted population, Brighton would stand out like a bit of a Volusia beacon. And I also think there's probably something for us collectively to start thinking about in terms of as we move forward towards really focusing in on the 13 ICT, the neighbourhood mental health footprints. Actually, how are we starting to look at things? How are we starting to triangulate our data on those kind of sorts of footprints? Because actually, it'd be really interesting to start to look at our safeguarding data by ICT footprint, and actually how might that then overlap with safeguard data that we might see from SCFT, etc., etc. So there's something over the course of next year where if we start to pivot the data, I think it would really help start to drive that conversation. But the report's excellent.
Good. I'm taking a bit more time on the quality side. We've got the one last report from Tuesday. I'll take a bit more time on quality because it's really, really important. We'll pull it back on the second part of the meeting. Last point, Fiona.
Okay. Last 3 points. But short.
Yeah.
Real short point. Yeah, it's just about the Ulysses. When the data came through, was there anything that surprised you? Were you surprised by the quantum? Were you surprised by where the different things fell?
Can you give the 3 points? What? Then it's easier.
I'd say all 3.
Yeah.
Okay. And then maybe I'll just keep it to 2. So just talking about the domestic abuse. So I just wanted to get a bit of assurance about how we're making sure that the cultural aspects of people's family situations are being taken into consideration, because obviously domestic abuse looks different in different cultures because of how people view things. I'll keep it to those 2.
Yeah. The Ulysses data, yes, and your colleague there, sorry, I don't know your name, commented about skewing just trying to understand, across the different areas about it. And one of the things we have spotted, yes, is in West Sussex, you'd expect there to be a higher number of incidents than elsewhere. I'm not quite sure why that is. Some of our theories around that, the data, are that some teams are better at recording it than others. Also in West Sussex, we don't provide so much the primary care counselling that we do in Brighton and Hove and East Sussex, and they put in a lot of safeguarding incidents, those teams, whereas in West Sussex, because we don't provide that service, they're not raising safeguarding concerns. So that's some of it. The domestic abuse bit, you're right about the cultural bits, and that was part of the reason that we implemented new training last year, because that is covered in the training. And it goes through the different groups who we'd expect to see differences around domestic abuse, and that relates to colour, race, religion. People with disabilities as well are more likely to experience abuse, and that is covered now in our new training to a higher amount than it was in the older training. I mean, I think it's something we also try and pick up in our individual consultations with frontline staff as well. And I think often it is that they're contacting us because they're not sure about the sensitivity of getting involved sometimes in those areas, and they want to get it right. So they come to us more often about that than perhaps some other areas of abuse.
Paul, thank you. That's really good. Thank you very much. Phil.
That's right.
Chair.
Nitin, yes.
Quick question, sorry. I know I can't raise my virtual hand for some reason, so you can't see it. But just one quick question. I agree with Colin's comment on the demographics, or to look at this data based on the population size. But the second question I had was, it's really great data, and with self-reporting data, you actually want to see more reported things, but obviously you want to see the trajectory going down over time. And as usual, my question is, what is that expectation sort of for next year? Do we see these numbers moving down, or do we have some targets for these numbers? What's the plan moving forward?
Thank you.
Thank you.
Thanks, Nitin. Actually, we want to see the numbers of referrals go up. Because what we want to see is that staff are recognising that there is a risk that needs to be explored. So a bit like any other incident, when we see data going up, that's helpful, and almost in a kind of contraindicated way gives us an assurance that staff are recognising that there is a risk. What we want is to see no harm, not high harm, but if you see more incident reporting of low harm outcomes, that will give me better assurance.
Thank you very much. And thank you very much, Phil. That concludes that report. Thank you. Finally, before break, Teresa, your consumer trust service.
Thanks very much.
At the beginning, just because this is in response to the Callacane report, and so the title of this paper is incorrect. It should have been updated so that we explicitly state that this is our response to the regulatory notice at Nottingham. And the reason I would want that explicitly stated is that if anyone did a search of our board papers, they would be able to directly find it and see it very quickly. The title at the moment is a bit ambiguous, so I hope don't mind me saying that at the beginning, but I know you did update it, but it seems the paper wasn't updated.
So, colleagues will return the information paper that was brought forward in October and related to the action required of the Trust by NHSE following the special reviews published by CBC in March and August of this year, following the conviction of Albert Callacane. Following the completion of the Community Mental Health Service review in September 2024, we identified areas of partial assurance in our assessment of treatment services. And we launched a task and finish group chaired by the Director of Clinical Governance and Quality Assurance to oversee the actions that came from the review. So in the last board information paper, we reported on the actions that would be focus of the task and finish group, and this is the assurance paper attached to that. So the task and finish group has a membership that includes clinical, operational and corporate leads. They have met 3 times so far, and this report reports on 12 key actions, of which 6 have been completed so far. The remaining 6 are of significant focus and mostly will be enabled via a new EPR system. So I'm thinking about this long term, thinking about how we embed these actions long term. EPR will support the embedding of actions, as will some of the transformation programmes, and David already mentioned the neighbourhood community mental health activities is one of those. So the work is ongoing. The task and finish will continue until the actions have been completed and embedded. And we're starting to have a conversation about the longer term basis in which we will have oversight of these key learnings, and we'll develop a way through our internal quality review to oversee the embedding of these actions for the longer term, and we will report those through policing. But ultimately, what I'm saying is we've made a good start. There is much more to do, and the embedding of these actions will be enabled by a number of the transformations and will be audited through the internal policy review cycle and even have oversight.
No, really good report, Trina. Thank you so much. It's so important, this, isn't it? And we can change the title of the paper. Yeah. Right, about the audit, but if somebody wanted to know what we discussed. Yeah, welcome to Kathy. And I'm just thinking about transition to neighbourhood mental health teams. Those are the neighbourhood mental health teams that will be part of the ICS neighbourhood team, aren't they? The integration there, which I think is actually very sensible. Just need to be. Yeah, my only sort of concern at this stage is it's like a lot of it, when you develop new teams and services, you can overload them, and this need to make sure we get it right. Yeah, but Kathy, I don't know.
No, I mean, I was just really interested in the inward investment on engagement workers, and then the 3 band 7 clinical leads. I guess I was just sort of interested to know kind of what kind of worker the engagement workers were. Is it a bit like a social prescriber, a bit like a health and wellbeing champion, somebody that's not necessarily clinically qualified but will get alongside people and support to engage with services? Is it like, yeah, okay. And is that one per neighbourhood team now?
I think that's to be worked out a bit, to be honest. But yeah, I mean, it's worth stating. So Sussex is a bit unusual in that it has assertive outreach teams.
Right.
And in Nottingham they didn't, and when we looked at our own services, we were assured about that part of the system, but not the ATSs. And so yeah, the idea is to have a much more engaging type of model, but that's linked to things like our DNA policy as well, which we need to review, as well as recording of things like diagnosis and so on as well. Yeah. So these are the other issues, but yes, so social prescribing is certainly part of the desired outcome of the neighbourhood mental health teams model. Whether we deliver that within SPST or whether that's a partner agency within the neighbourhood is I think of questions still.
You see huge potential of that neighbourhood working in terms of safety and sharing of information and data joined up services about.
Yeah.
As well.
Yeah. The key is designing them when you're working very hard on that and getting the right local population together.
On that point, to make the wider technology point by joining up with the Sussex Care Record and making sure that shared
social care record.
Sorry, joining up with the Sussex Care Record. We're not part of Plexus because of concerns over the quality of our care plans. Is that historical or is that current?
So one of the other areas of partial assurance is that we're doing an audit. I've got the figures here of people that should prompt us to be interested in this. So we identified 4,396 patients that will fit into this category. 3,238 were currently open and 1,158 were closed. The one where we are drilling down further, there are 190 cases that we probably need to go and have a look at, people who have been closed in the last 12 months or so. And we will be, so there's an audit looking at that. Part of the team basically is going into the individual cases themselves.
My plea was that as we're looking to integrate with the neighbourhood teams,
yeah,
wider technology over there too, and our new EPR with Sussex Care Record and those.
That exactly might be why Colin wants to come.
Yeah, so two bits. I think there's something for us that we have to have visibility across over the course of the next kind of sort of 12 to 15 months, which is a old EPR system and how much time and effort we're putting into sustaining that, and then how much time and effort we're putting into the new EPR system and making sure that the new EPR system is going to be fit for purpose for everything that we need going into the future. Yes, exactly. The other bit that's probably just worth us just being aware of, I just don't want us to lull into a full sense of security about. So the 764 investment was a scoping exercise that NHSE undertook, for which we were all just asked to put in submission. So from a planning perspective, one of the things that we will probably want to kind of consider as a board is what's our mitigations if we don't get that investment in, what does that mean in terms of the risks that are carried within this, and how we will be looking to kind of mitigate those who have workforce plans. So, and I don't think we're anticipating knowing from an NHSE perspective until probably back end of this financial year into early next financial year around whether or not that will or won't come through. So there's just something for us to internally think about in terms of that.
Yeah, so Kevin, I think I might have misheard you. So just on the EPR, so we have some integration with primary care currently through Plexus. So, but I don't think we have with did you call it the Sussex?
So that I think Plexus is the Sussex care record, isn't it? So I just read that it said that we couldn't do integration because of the care plan is not part of Sussex shared care record.
There's My Health Care Plan. Yeah. So
yeah. Okay. Thank you, Teresa. Thank you for the brilliant report. Thank you very much. So we'll look. Well, let's take the 15 minutes. We'll be back in 15 minutes. Thank you.
So we obviously met as a board in our board workshop a couple of weeks ago, where we spent quite a lot of time doing the deep dive into the trust strategy. So just to reconfirm that what we're being asked to review and sign off or to agree today is the content of the trust strategy itself. And then this will then go across to the kind of comms team to put together the final kind of documentations with the new trust branding, the new trust logos, etc., which is being well exhibited already in the room, Dan. Just to recap for board members, so obviously we started the piece of work to review our trust strategy at the beginning of this financial year. It's been a huge piece of co-production work. So we started off doing developing the state of the nation to give ourselves the kind of context or the case of change back in Q4 of last financial year. And that then led into a very large piece of sort of stakeholder engagement, where we worked with over 3,000 different people, whether that's people with lived experience, our staff, our partner organisations, over a range of different forums and kind of sort of groups. We worked through, and the board will remember that in August, we brought through our vision, our purpose and our values for agreement. And then since that time point, we then obviously have been working to refine that into our sort of strategic intentions, our behaviour framework, and then starting to kind of sort of put the detail together. What I just probably want to stress at this stage is that our kind of co-production approach was more than just going out and doing a kind of a big conversation and then bringing it back in-house and then doing the writing bit of it. So you'll see reference through sort of sections 2.8, 2.9, the level of engagement that we have tried to maintain through the entirety of the process. So we were still having meetings with people with lived experience and our staff, literally within a week of the product coming to the kind of sort of the board workshop. So that's how live we have wanted it to remain. It's been shared out with our partners. So Jane shared it out with her chief exec network. We've shared it out with the senior leadership team within the organisation. It went to the ICB. We've received feedback from a number of different partners and organisations. I think the main kind of commentary is often just around sort of the level of detail which we touched on at the workshop. And one of the things that we sort of explained is that we will obviously look at this as we develop the final product, and particularly thinking about the strategy on the page. But what was coming through really, really strongly, repeatedly from people with lived experience and our staff was around wanting the detail, because that's how they can connect and that's how they can see their thumbprint on the strategy. And if it becomes too high level, actually it becomes disconnected from what they were wanting. And I think we sort of talked at the very beginning about, our prime audience is about developing a strategy that is about our workforce and about the people that we are here to serve. There was a small level of refinement following the board kind of sort of workshop. So a few things around talking about the way we're talking about kind of quality improvement, some feedback around language, around the difference between deployment and delivery, which we've kind of sort of amended. And then obviously there was some further conversations that we'll pick up in Q4 in terms of three things. So one being, I think it was Nitin who wanted us to spend some time as the board really scrutinising the metrics, which we will pick up in the new year. We'll need to do the year one delivery plan for this. So being really clear around what are our priorities for next year based on the strategy and a lot of conversations that we're kind of sort of having. And then also we had the conversation around how do we want to kind of reflect this within sort of the kind of governance architecture that we have as a board and within the organisation itself. I don't propose to say any more about it than that. Obviously, it was kind of well rehearsed in the kind of sort of board workshop, but it's coming here today for us to approve the content of it and then note the next steps.
Great.
Thank you.
Colin, yeah, all you need to say, no, thank you very much. Yeah, the engagement has several times before, it's been impressive. And I'm hearing, you know, when I'm out and about and speaking to governors and other people that they're mentioning the strategy. So when I've been asked to join, I went to a strategy meeting, whatever, so I'll add that. Well, look, we've been asked to approve the content, we've had it, and thank you very much for bearing with us. I like these, they're all already starting and using things, so the values are good. Are we happy?
Yeah,
Yeah, and it's in, I did think about the point about the scrutinising the metrics, and there's further work to be done on that, and we can built in. Yeah, okay, thank you.
Thank you very much.
It's great, it feels really good, you know, well done, your team. Yeah. We don't often do we?
You've just got to deliver it now.
Yeah, I know. Very good. Next up, so on to the next section, which is performance and the quality and performance report. First one, John. Yeah, John.
I wonder if it's Usman.
Oh, sorry. Okay. No, Usman, yeah, you're down here too.
It will definitely be a team effort. Don't worry, Chair. So I will just let me start, and then we'll get into sort of questions, and colleagues can come in on specifics. So, good afternoon, everyone. Thanks for let's go through the IQPR. So I'm just going to take you through some key highlights, both positive achievements and areas requiring further focus, as well as the actions that we're sort of taking to implement or address some of those challenges. So I guess just to start, in terms of, you'll see in the report, we've set it out slightly differently, just to really draw attention to those areas against the core metrics as we described them, those areas that are either improving or those areas where we've got concerns. In terms of some of the key improvements, I think Jane alluded to it earlier around all the work we've done in workforce, but I think staff appraisals, again, continue to see that improvement, and we're now at 91.2%, which exceeds our target of 90%. It's taken quite a long time for us to get to this sort of sustained improved position, and I guess ties into the conversation we had earlier around one of the ways that we've reduced our agency bill and our reliance on agency staff is by trying to keep our own staff, reduce turnover rates, improve retention, and we know that supervision and appraisals are a key part of that. So I think it kind of all ties together. Linked to that agency spend, I do want to draw attention to it. I know it's within the finance paper as well, but it is one of our core metrics as well that we look at through the Trust IQPR. Agency spend is now 6.7% of the pay bill, which is still higher than the national target, but significantly lower than it was this time last year. In fact, this is the lowest it's been in 2 years. So I think, again, Jane alluded to the sort of financial sustainability team and the award they got, but that recognises all of the work that's happened across the organisation. And I think in particular, the implementation of the Cascade programme, while it's been challenging, has clearly demonstrated the benefits in that outcome. And then a couple more just to highlight. I think we've talked a lot over the year, and I think we talked during the strategy work as well around that focus on outcomes. And while there is still a long way to go, the uptake of patient-reported outcome measures continues to improve. And over the two, we're now the best place we've been in over sort of the last couple of years. In terms of the percentage of patients with paired PROM scores, and our target is to reach 25% by March 2025, and you know it looks like we're on our way to achieving that. there are other things I could talk about in terms of sort of inpatient flow continued around the work that we've done around the out of area placements. That continues to flag as special cause improvement. I think there'll be a question for us as we move into next year whether that remains one of our core metrics, given that we have now sustainably maintained that for over 12 months at that position. And the patient experience surveys, the response rate, I think, had risen to the highest again over the last couple of years. So I think great work that's happened there, but again, questions as we go into next year around what core metrics will look like. In terms of some of the key areas then, I guess, to flag for concern, I won't dwell on risk assessments and care plans, given that Jane picked that up already. And all of those points stand in terms of how are we going to try and achieve this and the additional focus that we're going to need to put on this. So I guess the other two things I just wanted to really highlight, we haven't sort of necessarily talked about them in lots of detail before, but it is clear that we have seen a trend upwards in both sort of violent incidents and physical restraint incidents. And I think the deck sets out relatively clearly that those are in sort of relate to very small number of patients, largely in our secure areas. But I guess it is important that we don't lose sight of it, even though we do know that it's related to a sort of small number of patients with particular challenging presentations. It's still something that we will need to keep focused on, and it links to the point we've made previously around Statman training and PMVA, sorry, you'll have to forgive me. And so I'm sure if there's questions, we can come on to those. And I guess sort of then the next section, just to highlight in terms of area of concern, that in the deck we talk about what we are going to try and do in terms of sort of the actions around talking therapies. So we had seen a level of deterioration against 6-week target and access. But I think the deck sets out the sets of actions that we've been taking, both in terms of recruitment that commenced in September and the use of independent sector, which will, I'm happy to say, commence very shortly, so that we should be in a position to recover both of those trajectories. And the one I want to highlight, I guess, that we don't really have at the moment an action plan to be able to address, but it's not possible for me to talk about our wait times without sort of talking about the ND wait list, which has now grown to over 16,500 people. Unfortunately, we are not an outlier in that necessarily. There's been some well publicized sort of work that had been done by others that sort of shows where everyone is on this position across the country, and that remains an area of significant concern, and one that we're working with our system partners on as well, in terms of the things that we can do to try and address that. Although I guess it is always worth highlighting when I talk about it that we have got our own internal risk stratification process, and we do go through that overall PTL to make sure that those people who are assessed as being most at risk or most needing to be assessed and then subsequently be offered treatment will be prioritized as such. That's a really high level summary, Chair, of the sort of IQPR. I'm conscious that rather than me just listing it out, it's probably better to just take questions from colleagues, or whether there are particular areas exec colleagues want to draw out.
Yeah, so the exec colleagues, why don't we just get a couple of the execs and we'll.
Thanks, Chair. It's always a slight challenge because the data in here is the end of September, and we will be looking internally through our own quality performance reviews at October data, and of course, and to some extent actually November as well, because we're reviewing it live in the month. So I guess it's just a couple of areas just to point out to the board where we have seen some improvements that haven't necessarily come through in here. So one is around clinically ready for discharge. So this is something that we've spent a lot of time as a board talking about the impact that has, the patient safety impact that has, the patient experience on people being able to access inpatient care in a timely manner. I'm very pleased to say that we have started to see a reduction in both the raw numbers of people who are classified as clinically ready for discharge, but more importantly, the length of their delay, with particular focus on West Sussex. So we should note thanks to West Sussex County Council for that. You've heard me describe here before the work that we've been doing with Empower, which has been funded by the National Better Care Programme, and that will manifest itself more in the new year. Usman's already covered talking therapies, and I think when we see next month's board report, you'll start to see further improvements within some of the talking therapy metrics, and then from January, the capacity that's been procured in the independent sector. I would just like to mention memory assessment services. Again, the board will remember that we paused our memory assessment services earlier this year as part of the financial recovery programme for last year. We've seen the services recover to the same level of activity immediately that they were doing prior to the closure, and within East Sussex in the last month they have exceeded what they were doing previously with a reduced staffing number. So in terms of the productivity within the service and the clinical model, that's an area that we focused on quite considerably in our QPR processes. And final point, just to Usman's point around the adult ADHD waiting list. I'm sure Oliver may wish to talk more from a clinical perspective, but from a management of the waiting list, we have started a process of clinical validation, clinical and administrative validation of the waiting list to ensure that it is as clean as possible and that the right people are on it, and that we're communicating with them. I think I have to say that will be a 6 to 9, 12-month piece of work, given that the scale of the waiting list, as Usman described, with 16,500 people on it. But that's something that we're taking forward at the moment. Happy to take questions across any of the areas. Absolutely. It doesn't improve the patient experience materially, but it is a mitigation to some extent.
Can I just say really quick, I'm glad you pointed about the clinically ready for discharge numbers. That's really important, because I know that's an area where we've kind of particular focus on, and that presumably then helps with the ways of people in the departments, because more beds. I know we're not significant yet, but we need that flow to.
Absolutely. I think it's important to say that, you know, our average waiting time for a delay is in excess of 50 days. It's far longer than we would like. But in terms of the progress that we've seen and the support that we've received from local authorities, it feels considerably different to how it did perhaps 6 to 12 months ago.
And we acknowledge that our local authority partners are under a lot of pressure.
Absolutely so.
Dan, please.
A couple of points from me, the on patient experience. So the Sussex Experience survey response rate is positive. Our response rate at the moment to the annual community mental health survey is stuck on about 18%, which is 2% down on last year, puts us average in comparison to our to other mental health trusts, which is disappointing. A couple of days to go, so it may move. The other point I wanted to make, just coming back to the complaints discussion we had earlier, John's point about the reporting period talks to that point about the decline we've seen on response rate in October and November. I did want to relay the point as well that our improvement programme around complaints relates to tone of voice, clarity of content and responsiveness. And whilst that last element, the performance isn't where it needs to be these last 2 months, the other two areas of quality, we've seen a significant improvement in quality over the last 15 months. So I just wanted to make that.
2 points. In the dashboard quality safety, note the patient safety litigation, whereby reached their overdue time. That's reduced to 45, which is not where we have stood up 2 extraordinary 4 days for witness. First of goes tomorrow, first in the 7th of December, got the exec support and oversight in this days with me. So just to update and it's extremely important to us from the perspective of experienced families and not into contact. Usman mentioned violence and aggression, and we have developed a flow chart for the application of response to staff that have been impacted by violence and aggression. in support in collaboration with those team. So staff now in services, and especially clinical leaders, have access to that flowchart and continue approaching in a really responsive way. Staff that have been affected by violence. And linked to that, we've spoken earlier about physical restraint incidents on increased rate. One of the focuses of the QPR last week was prone restraint. So we have set some clear expectations around the reduced use of prone restraint.
National scrutiny.
Yeah, we have also had 2 patients transferred to hospital this week.
Yes.
On Monday and one on Tuesday. Was significant to the experience of those people and that will see a reduction by the aggression because it's being
100%.
absolutely understand.
That's good. So the height.
Can I answer my question? You're going to take a bit, Stuart.
Thank you very much. And
Question, Chair. Thank you. First of all, just a comment on the complaints response percentage. I think we've done a really good job looking at it from last year to this year. Getting to 80% is really, really commendable. I know that number was lagging all of last year, but we've been on the up and sort of maintained it, which is great. The second question I had actually was around, Usman talked about the agency pay spend where we're doing a great job. The staff turnover is lower, which is helping that agency spend being down. The one thing that is a little bit worrying is the new joiners being down. And I'm wondering if that's going to be, or that might be an issue as we continue to get that expense of agency spend down. And if the exec team shares that concern and what we're doing about it.
Yeah, no, new joiners isn't good. Who wants to sponsor? I mean, I'm thinking Zoe.
Do you want me?
Yeah. Oh, how about Zoe, then you, Usman? Zoe, yeah.
Thank you. So in terms of new joiners, I get assurance from the level of internal redeployment that we will be experiencing resulting from our transformation changes. So whilst there is a high level of or a reduction in our new joiners, what we know is that we have held posts internally to provide for opportunity for internal redeployment. That has now been released.
Yeah.
So I'm anticipating that changing in the foreseeable next couple of months.
Logical response there. Yeah. Okay. That's yeah. Good. Usman.
I think Zoe's covered off the main point about related to the cases for change in effect and creating that headspace. I think it's just important to note as well that the board approved plan at the start of the year showed us having in effect a reduction in whole time equivalents. So we're not expecting to see any material increase in effect in the net number of whole time equivalent joiners. Will continue to ensure that we prioritize recruitment into clinical roles, but that's being offset in effect by the reduction in non-clinical corporate and some agency roles. So I think it's just important that we note that.
Okay, thank you very much. Thank you very much. We'll move on now to the finance report.
Thank you, Chair. So again, I'll just give brief sort of overview of this and then happy to take questions. So I think that the key thing just to note at month 7 is that there was an update to our plan. You'll notice on slide 2 that our overall annual budget has now shifted to 0, i.e. break even, which represents an £18.6 million improvement from where we were in previous months. And I guess just to formally note what that reflects is that, as we said at the start of the year, organisations who were delivering their plans were on track to do that, which we have been, would then be able to receive their deficit support funding. For us, that means that the deficit support funding that's been released to us means that we will now be in a break-even position. I think it's important to note it, but the things that it's really important to highlight within that statement is that is non-recurrent deficit support funding. We have no indications as of yet. Planning guidance has been issued, so we're not clear what that means for 25-26, but for 24-25, it is non-recurrent. So our underlying position remains one of deficit, which is why the work into next year to continue to take out the second half of that £50 million underlying deficit is so important. So that is kind of just the key sort of change around the plan that I think is important to note. In month, therefore, you'll see that we actually reported on plan. We're reporting largely a break-even, materially a break-even position. If I was to just draw people's attention to the fact that, again, I know I highlighted it earlier, but our agency spend continues to reduce, and I think testament to the work that's being done. In terms of our CIP position, we delivered almost £2 million of CIPs in month, and that's in line with the increasing trajectory that we've talked about before. We all knew that our plan was going to require us to deliver more savings within the second half of the year. But we had commenced all of the work, all of the cases for change, all of the corporate services reviews related work, the estates related work, all of that had begun in half one, and we are now starting to see all of that come through. So at this stage, we remain confident that that will deliver as intended. Within the detailed positions, I think it's worth just highlighting that we continue to see operational pressures on, well, operational cost pressures as a result of maintenance and premises costs within estates and facilities. And I think it's important just to highlight that, because while we have spent time talking about Coombe Valley and the sort of success that that program is going to be, once that site is complete, we will have to think about the rest of our estate. We have got challenges, and at the moment we have no source of confirmed national funding for how we would potentially replace some of our sites going forward. I know we previously have talked about phases rise 2 and the requirement and need for it, but I think what we're really starting to see now is that monthly spend on sort of emergency maintenance and sort of critical things going wrong is starting to increase. We're starting to see sort of over £100,000 a month worth of extra costs being incurred, and I think as we get into 25-26 will form key part of our thinking around the plans going forward. Chair, the only other thing I just wanted to draw people's attention to was, again, within the workforce position, we did just briefly touch on it, but I guess it is just noting that workforce plan for the trust that we signed off at the start of the year was to take us down from about 5,800 whole-time equivalents to circa 5,400 whole-time equivalents. We've set out the waterfall for how that was planned to be delivered, and on slide 10 you'll see that on table 2 within slide 10 you'll see that we are on track to do that. I think the one thing it's just important to recognise is, because of the extraordinary levels of care required for some of our exceptional packages of care, as we describe them, but that's in effect the additional support and staff required to support some specific patients, our headline number shows that it is above the whole-time equivalent plan. But we have explained that with sort of our national regulators, and Zoe and I and Funmi have the joys of joining monthly calls where we talk about our workforce plan. So I guess it's just so that we are really clear. Our headline reported number appears if this is over plan, but once you allow for the specific exclusions related to those EPCs, we're at plan, materially at plan on our workforce position. In terms of the capital programme, I think it's, again, hopefully clear, but against a core capital programme, i.e. the £6.5 million, that is sort of within our own allocated core CDEL, we are broadly on plan and confident that we will deliver. We'll spend all of that. In fact, we will probably spend slightly more than that. And we're trying to just work through how we mitigate that before signing off a finalised forecast for month 8. But we are at this stage still quite underspent against the Coombe Valley Hospital programme because of the sort of weather-related events earlier this year and at the back end of last year. We are confident that we will deliver to the program timetable for this year, i.e. we will spend all the money that is set there, but there is some risk given the recent rain as well. We don't yet know whether there would be any additional weather related events. We're currently in discussion with Keir, as you can imagine, to ascertain that, but we hope that given it was an extended period, there shouldn't be any material further delays, but we'll keep the board updated as we get further information. Chair, I'll stop there and happy to take questions.
That's really good. Thank you for both the sort of level of confidence that you have regarding the rest of the year finances in relation to the fact we've started the case of change corporate services review. So it's really good to hear that, hear a look at the detail of that. And then the capital spend, the confidence on that, it's really important. Just on the cost pressures for the estates, we'll have to do the internal thinking for that, but we're going to need some help. And we've got some national influencers coming to see us soon, haven't we? We've got Lord Victor Adewale coming down in January, and there is a plan for Claire Murdoch to join us. It's the examples of that will be helpful because they'll go away and lobby on our behalf. Good stuff. Kathy, please.
Just it's probably just being a bit dim, really, but the 18.6 million non-recurrent. If we deliver our 25 million CIP next year, have we dealt with that underlying 18 million deficit? We're not with some non-recurrent investment next year if we deliver our SIP next year.
Yeah, so if we, all things being equal, if we were to deliver the SIP program for next year as currently planned, we would deal with, I'll say, the material amounts of our underlying deficit. We would, in effect, have largely covered it off. There are, as you can imagine, a few small moving parts to it, but broadly, the message would be if we deliver our CIP program next year, as we have this year, then we will have dealt with the most material elements of our underlying deficit.
And there's related to that is looking forward into 26-27, where we know we've got investment into the NHS next year significantly, but then a drop back in 26-27. So how far ahead do we need to be sort of thinking? Because you described the pipeline for next year, we need to be maintaining foot on the gas, really. But it's perhaps a bit premature for that question. So well, I think
I don't think it is. I think it's a great. Sorry, Chair. Sorry. No. I'll clarify. I was going to say. So we're going to have a conversation in private later, just sort of some high level. What does 25-26 look like? But I will say that while a lot of work now is happening on 25-26. I and some of the others were starting to think through what does 26-27 and 27-28 look like, because I think for us there are a number of big programs, both Coombe Valley Hospital opening, the new EPR implementation, that mean there are a number of factors we need to think about, and they go beyond 25-26. So I think, one of the things I'll say is when we first started sort of this process in 22-23, we were thinking 2 years ahead at that time, and I think we have to sort of keep with that kind of process, because the fact that we're able to get to where we've got to this year, I hope, touch wood when I say that, was largely because of all the work we started back at the end of 22-23. And I think it's going to have to be that same challenge from you to us around actually what did you do, not just about next year, but about the following year as well and the year after.
I was going to say the same thing. Thank you for bringing it up, because it gives us a steer to what we should be doing in our board workshops and our strategy time that we have thinking for those years ahead. Spot on. Thank you very much, Usman, not only for the report and presenting the report, but the work that you and your team are doing to steer us in. Thank you. We're aiming for and working with your exec colleagues, because it is a team effort. So audit committee report, Nitin, please.
Thanks, Chair. I'm going to keep it pretty brief. Very standard audit committee. Last one had the usual updates from internal audit, counter fraud. We had external audit outline the annual draft plan for the following year. We will be looking at the final plan in our meeting in January. We did have a look at the board assurance framework, but based on our discussion at the workshop a couple of weeks ago, we might want to look at that as a board again, but aside from that, nothing more to raise to the board.
Thanks, Nitin, very much indeed. Any points or comments? The Charitable Funds Committee report. Sean Duggan. So yeah, well, you've got the report here. There's really not much to add, other than the fact that the charity, with the help of me and Colin, because the charity reports to exec by Colin, doing some work around the purpose, strategy for the charity alongside our overall strategy, and it has been quite useful. Just to reassure the board, particularly as we help fund the charity to make sure it works and it delivers on its objectives. What we need is the charity's activities to link with the work that we do as a partnership trust, and it does help with a bit of the innovation, a bit of creative work that we don't always get funding to do. It's small funding, but it is nevertheless quite important. And I think it's going. I'm happy with the way it's going. I have a level of confidence that the charity keep doing a good job for us. And we're already starting some discussions about how the charity can help us in funding our staff positive practice course into next year. Thank you very much. And the sealed documents report, Adam.
Thank you, Chair. So as per the trust standing orders, the board are presented a biannual report on those documents that are sealed. You'll note this report captures that period from April the 1st through to the 1st of October, and includes information and detail of the documents and that are sealed. All of those are sealed and witnessed by 2 executive directors as per the constitutional requirements.
Good. Yeah. Okay. And do we have any other business? Thank you very much. It's quite hot in here, isn't it? All of a sudden, well, I'm very hot all of a sudden. But we'll close the meeting and we'll meet again in private at 4 o'clock. Thank you very much indeed.